If we were to compare or look at neuropathy, I want you to look. The column in the middle is the feature, and I want you to circle whether it's which side of this table it's on. You got it? So I want you to circle the correct answer. The patient comes in with neuropathy. We're looking for symmetry. Is it symmetrical or asymmetrical? Symmetrical. Circle it. When a patient has neuropathy, what's their sensation that they describe? Burning, weakness, and sensory loss. Circle it. When a patient has neuropathy, the course of neuropathy tends to be very variable. All right? It's very unpredictable. How quickly does it progress? Rapidly, right? So it doesn't come on over 10 years. It's a rapid progression. Circle rapid. Extremities involved in polyneuropathy. Upper or lower? Lower much more commonly. And what about the symptoms? Are they proximal or distal? What about your diabetics? Distal, exactly. So I'm not feeling the loving here about neuropathy. All right, so you know what clues to look for? We just went through them. So look, we look for symmetry. We look for burning, weakness, sensory loss. We look for a variable course. It often is rapid. It's more likely in the lower extremities. And it happens distal to the trunk, not proximal. All right, everybody got it? Keep those in your brain. You might see them again. I'm changing gears. Let's talk about tremors. When a patient comes in with complaint of a tremor or you observe it, your brain has to flip to the tremor algorithm. Is it a rest tremor or an action tremor? What's the most famous of the rest tremors? Parkinson's, exactly. We'll talk about it briefly. But an action tremor obviously occurs in the course of movement of whatever the limb is. So look at the Parkinson's man. I'm pretty darn sure you've met him before. He's probably appears in every neurology book that you've ever opened. And look at the average age, 70 years old. Which makes you realize right away that Michael J. Fox is not the average Parkinson patient, right? He was very, very young when he was diagnosed, so it tends to be older patients. When patients come in, you need to have a heads up about what you should be looking for. The clue is a tremor at rest, and the clue is a pill-rolling tremor. You remember a pill-rolling tremor? All right, so we look for that, bradykinesia and rigidity. Typically in primary care, you are the first person to identify these patients. Typically when it presents, it is at least initially unilaterally. If you were to see a question on the exam that asked you about first-line treatment for Parkinson's, you might be thinking, I'm not treating this patient, they're going to neuro. That's exactly right. However, levodopa, if you were to see a question like that on the exam, that would absolutely be the right answer. Typically, it's first line, it's very effective. It's got a horrible side effect profile, as many of these medications do. But what's your job? It's going to be to punt. All right, so we send them over to specialty care. So you may run into Parkinson's patients every now and then, but probably with regularity, at least once monthly, depending on how busy your practice is, you're going to run into patients who have essential tremor. It typically is familial. It's more common as people age. And when it is familial, look at this. About 50% of them who have autosomal dominant trait are going to have it. So it's very, very prominent in families. And that usually is a good historical question to ask a patient who presents with one. It doesn't just involve the upper extremities, although that's most common. Rarely it involves the lower extremities. But it's common with the head, the lip, or even the vocal cords. Haven't you heard a little old lady tell you something about her husband? And she's got that little squeaky voice. I mean, it could be a vocal cord tumor, but it could also be a vocal cord tremor as evidence of an essential tremor. So just as an FYI, I want to make sure you know that. The other thing I want you to know or have an idea about is how do we treat essential tremor? Because you can't send every one of those to neurology. The way that we manage that first line with medication is a beta blocker, a drug like propranolol may very well help the symptoms that these patients will present with. I'm changing gears. What about MS? MS, I think you may see a question on your exam about. I don't know how long it will take you to run into one of these patients, but I think you'll see them in primary care. It's immune-mediated. It's a demyelinating disease in the central nervous system, and your most important thing to do with these patients is to get a good history and to do a good physical exam. Let me tell you what you'll find in history. What you're going to find is that the patient relates, first of all, they're not a 70-year-old. They probably are not 60, and I doubt they're 50. They tend to be a young adult, 20, 30, maybe 40 years old, and they have one or more distinct episodes of dysfunction in the central nervous system. One or more distinct episodes of dysfunction in the central nervous system. That is a historical piece of information you need to pull out of that patient. What kind of sensation? To be honest with you, the most common one is limb sensation. I'll tell you, it feels like my leg vibrates, it gets numb, whatever. We often see loss of vision, monocular loss of vision, and then it may come back. So historically, you got to pull this information out. You don't have to diagnose them. You don't need to do the workup. When you hear those symptoms, your job is going to be to say to the patient, you have some symptoms that I find very concerning. I would like for neurology to see you. Are you willing to go? Let me set up the appointment for you. So that's your job, but you have to be the person who picks up that information in history so you know where to guide them and where to send them. All right, everybody with me? Let's talk about dementia and then we'll wrap things up. Dementia really is a decline in cognition. That's what it is. And it happens insidiously over a period of years or months. It doesn't happen overnight. It doesn't happen this week. We see decline in one or more of these domains. By DSM-5's criteria, the domains are complex attention, executive function, which means your ability to manage your calendar, learning and memory, motor, and social cognition as well. So there's something that is just not quite right with these patients. But your real good historical clue, the thing that you're going to have to get, not necessarily from the patient, but someone who may have come with them or who can be a good source of history on the telephone for you, is that it interferes with daily function and independence. All right, that's the big clue. That's what's got to make you think about dementia. That is always contrasted with, is this a normal finding that we see with aging? So don't laugh, but let me tell you this quick story. No matter what decade you're in right now, second, third, fourth decade, sixth decade, wherever you are, your ability to learn new information has slowed with every decade. When you were 2 years old, your ability to pick up new information and your rate of learning was more rapid than the fastest computer on this planet. That's how quickly you learned at 2 years of age. But with every decade that has passed, your ability to learn new information has slowed. And so sometimes it's very noticeable when the patient is 80 compared to when they're 20. So difference between a 20-year-old and an 80-year-old with cognitive processing can be remarkable. That's not dementia. That's a normal function of aging. An 80-year-old does not learn the information in your syllabus as rapidly as you will. All right? Normal changes that occur with aging do not affect independence, and they do not affect the patient's ability to function. All right? So there's a big, big difference between dementia and the normal changes that we see. So is this real common? Oh, yeah. If you've been in a hospital lately, you've been in a clinic lately, you've been in a lot of different places lately, you know this is darn common. Look at the numbers. By 85, up to half of older adults have dementia. That's a lot. That's huge. There's a new commercial for Alzheimer's disease, and I don't know if y'all have seen it. It says, someone is alive today who's going to be the first living survivor of Alzheimer's. Like, that's kind of a big deal. It's probably the ailment that will get half of the people in this room. And I don't know if you've thought about it, but it's a really big deal. It's extremely costly, and these patients need loads and loads of care. What's your initial approach when a patient comes in? Either someone brings them in, an adult daughter, a son, or maybe you notice this because this has been your patient for the last 3 decades and you realize she's not what she was last year. Something is going on with this lady. Well, we don't have a blood test that says you have it. We really don't even have an imaging study that says you have it. What your job is going to be is to determine whether this is normal or something else is going on. And what must always be in your differential is whether or not this is delirium, because delirium is something that happens very rapidly this week, yesterday. It happens quickly. What are you going to do? You're going to get a good history, but it also means that you get a good history from the patient and from somebody who knows the answers to the questions you're asking. And so you got to compare what the patient tells you with what you know to be the true answers. So history is key with these patients. In primary care, there is a test we use. I think you'll see it on the exam. But we use it in primary care because it takes about 7 minutes to administer and you don't have to do it. Somebody in your clinic can do it for you. It's pretty darn high sensitivity and specificity for dementia. And the test is a mini mental state exam. If the score on this exam is less than 24, it's strongly suggestive of dementia. All right? So the mini mental state exam we use in primary care, quick, good sensitivity and specificity, and somebody else can do it, you will review the results. You then need to do a good physical exam on them. And you know what you're always looking for? You're looking for some condition that will masquerade as dementia. Let me ask you something. How embarrassed would you be if somebody got put on an anticholinergic med and began to have bad cognitive changes and you didn't pick it up? Suppose somebody developed a B12 deficiency and you didn't pick it up and they got diagnosed with dementia. So you are always looking for something that is masquerading as dementia. In older adults, you must do a thorough medication history. I like to call that the brown bag test, right? You got to do that. Diagnostically, these tests are typically referred to as low-yield tests, meaning they're always normal. Normal makes you think it might be dementia. So you can see that a B12 and folate level are part of them. So is a TSH, right? So anyway, you're looking for things that can masquerade as dementia. And I'll just tell you right now, as you well know, these are difficult patients to take care of. They don't adhere to their plan of care. They don't tell you when something is wrong. They're a challenge to take care of, but they're even a greater challenge for their caregivers, their family, and whomever. So what do you need to know for the exam? With regard to patients who have declining cognitive function, safety is huge. Safety is huge. So you always want to focus on an issue that focuses on safety. If you get a question, it's always what keeps this patient safe. You've got to think about their ability to live alone. Because remember, the ability to not be able to take care of yourself is one of the things that makes this dementia and not something else. Caregiver burnout, please put a star by it because I think you'll see a question on the exam about it. And elder abuse, I think you'll see a question on your exam about that. All right? So just know what the clues are about elder abuse. And to be honest, know what the clues are for caregiver burnout. Whew, take a big, deep breath and let it out. All right, let's take a look. You know that both exams have the potential, when you click next question, to pop up an image. And they'll show you a picture and they'll ask you a question about the picture. So let's pretend you just click next and this image pops up. And here's what you get. This 75-year-old female complains of pain along this vascular prominence. What are you thinking of? What's the likely diagnosis? Temporal arteritis, right? So temporal arteritis, an inflammation of the temporal artery, diagnosed with a temporal artery biopsy, always referred. Look at your next patient. A 30-year-old NP who is a recent graduate has a job interview. She feels very anxious and has a noticeable tremor at the time of her interview. Oh, Lordy. We've all had this kind of tremor before. If you've had too much Starbucks, you've had this kind of tremor. What kind of tremor is that? It's a physiologic tremor. Do we treat it? No. So number 2, look at your next question. A 72-year-old female describes intermittent facial pain along the right side of her face and head. It's sharp, piercing, and it started last night. Her neuroexam is normal. Intermittent facial pain, right side of her face and head, sharp piercing started last night, normal neuroexam. Do you need a CT? No. What does this sound just like? Trigeminal neuralgia, right? Is the age fit the diagnosis? Yes, right? I'll circle number 4. Whew. Okay, so listen. I want you before the course or after the course is over to make a list of those things that need more review. Those are the ones with the exclamation point, but there's another list you don't have to make, but I know you got one. It's a list of things you probably decided, I'm not learning that. If they ask me that, I'll just miss it. Oh, you have that list, huh? I had that list too. And what was on my list were these darn cranial nerves. I thought, you know what, I'm just picking A. My name's Amelie. It starts with an A. I'm picking A if I get a cranial nerve question. I think you may see one. It refers to cranial nerve 2, which is vision. And so, anyway, I would encourage you to review them.